Dear students, in this lecture we are going to talk about the toxicity of nonsteroidal anti-inflammatory drugs, which are also known as NSAIDs, and this is part 1 of this lecture. At the end of this lecture, you would be able to identify pharmacologic actions, pharmacokinetics and toxicokinetics, and also to determine the pathophysiological effects of nonsteroidal anti-inflammatory drugs. At the beginning, let's take a simple idea about nonsteroidal anti-inflammatory drugs. NSAIDs are considered among the most commonly used and prescribed medication in the world. Concerning their pharmacological actions, they have analgesic, antipyretic, and anti-inflammatory properties. Most of the beneficial effects of NSAIDs result from the inhibition of cyclooxygenase, which is abbreviated as Cox enzyme, that enables the synthesis of prostaglandins, which in turn mediate inflammation and fever. In addition to the benefits of NSAIDs, some deleterious and life-threatening effects are associated with both their therapeutic use and overdose. Please keep in your mind that the term NSAID used in this lecture does not refer to salicylates, which are unique members of the NSAID class and will be covered later in another lecture. Pharmacology. In order to understand the actions of NSAIDs, we need to revise the mechanism of action of these drugs. All NSAIDs share the ability to inhibit prostaglandin synthesis. Prostaglandin synthesis begins with the activation of phospholipases, commonly phospholipase A2, that cleave phospholipids in the cell membrane to form arachidonic acid. Arachidonic acid is metabolized by cyclooxygenase to form many eicosanoids, including prostaglandins and the prostanoids prostacyclin, which is prostaglandin I2, and thromboxane A2. This figure illustrates arachidonic acid metabolism. The precursor of prostaglandins is arachidonic acid, which is released from the cell membrane phospholipids through the action of phospholipase enzymes. Arachidonic acid is metabolized through the action of cyclooxygenase enzyme into prostaglandins, prostacyclins, and thromboxanes. There are two isoforms of Cox enzyme, which are COX-1 and COX-2. NSAIDs and selective COX-2 inhibitors bind reversibly to Cox enzyme, while aspirin causes irreversible inhibition of this enzyme. Arachidonic acid can also be metabolized by lipooxygenase into hydroperoxyeicosapentaenoic acid, which is converted to many leukotrienes. Previously, we mentioned that there are two isoforms of Cox enzyme, which are COX-1 and COX-2. So, where are these isoforms expressed and what are the functions for each one? COX-1 is constitutively expressed by virtually all cells throughout the body, but is the only isoform found within platelets. This enzyme produces eicosanoids that govern housekeeping functions, including vascular homeostasis, gastric cytoprotection, and renal blood flow. COX-2, on the other hand, is rapidly induced within 1 to 3 hours in inflammatory tissue producing prostaglandins involved in the inflammatory response. However, COX-2 is also expressed constitutively in endothelial cells. Different NSAIDs display different levels of selectivity for the COX-1 and COX-2 enzymes. Some NSAIDs, for example meloxicam and nimesulide, preferentially inhibit COX-2 over COX-1. Others were specifically designed to selectively inhibit COX-2, for example celecoxib. COX-2 inhibitors have the ability to inhibit endothelial-derived prostaglandin I2, which blocks platelet activation and causes vasodilation. But combined with their relative inability to inhibit platelet-activating thromboxane A2, a predominantly COX-1 effect, they may shift the balance toward thrombus formation. That's why many of the selective COX-2 inhibitors, for example valdecoxib and rofecoxib were removed from the market because of their increased risk of adverse cardiovascular events, such as myocardial infarction and stroke. Pharmacokinetics and toxicokinetics of NSAIDs. Most NSAIDs are organic acids with extensive protein binding more than 90% and small volumes of distribution of approximately 0.1 to 0.2 liter per kg. Oral absorption of most NSAIDs occurs rapidly, resulting in bioavailabilities above 90%. Time to peak plasma concentrations achieved by NSAIDs can differ widely. NSAIDs differ with regard to their sites of both action and accumulation within the body. For example, significant synovial concentrations are attained by indomethacin, diclofenac, ibuprofen, and piroxicam. Serum half-lives with therapeutic dosing vary from as short as 1 to 2 hours for diclofenac and ibuprofen to 50 to 60 hours for oxaprozin and piroxicam. Most NSAIDs undergo hepatic metabolism with renal excretion of metabolites, whereas diclofenac undergoes extensive first-pass metabolism. 10% to 20% of indomethacin are excreted and changed in the urine. This table shows classes and pharmacology of selected NSAIDs. There are three main classes of NSAIDs, which are carboxylic acids, enolic acids, and COX-2 selective inhibitors. Some examples have been mentioned for each class with the time to peak plasma concentration, half-life, and the metabolic pathway for each one. Pathophysiology. The first effect is the gastrointestinal toxicity. Gastrointestinal toxicity is the most common adverse effect from NSAID use. First, we are going to explain the role of prostaglandins in maintaining gastrointestinal mucosal integrity. Normally, the COX-1 enzyme expressed in the gastric epithelial cells leads to the production of prostaglandins, which are prostaglandin E2 and prostaglandin I2, which are responsible for maintaining gastrointestinal mucosal integrity by increasing mucus production and decreasing acid production. Now, how NSAIDs can cause gastrointestinal damage? NSAIDs not only inhibit the production of these cytoprotective prostaglandins and platelet aggregatory thromboxane A2, but also have a direct cytotoxic effect, increasing the risk of gastric and duodenal ulcers, perforations, and hemorrhage. After understanding the role of COX-1 in maintaining gastrointestinal mucosal integrity, it would become apparent why selective COX-2 inhibitors decrease the incidence of significant gastrointestinal toxicity compared with some non-selective NSAIDs. Effects on the kidney. Locally, the kidney produces homeostatic prostaglandins largely via COX-1, including prostaglandin I2, prostaglandin E2, and prostaglandin D2, which cause renal vasodilation and maintain renal blood flow and function. Under normal conditions, prostaglandins exert minimal effect on renal perfusion. However, when kidney function becomes compromised, such as in case of congestive heart failure, the production of prostaglandins becomes significant to maintain renal blood flow. Patients with volume contraction in case of dehydration or poor cardiac output in case of congestive heart failure have elevated concentrations of renal vasoconstrictor substances from stimulation of both the renin-angiotensin-aldosterone axis and the sympathetic nervous system. In these patients, NSAIDs inhibit the synthesis of the compensatory vasodilatory prostaglandins, resulting in unopposed renal vasoconstriction and causing decreased renal blood flow and glomerular filtration rate. This effect may possibly lead to acute renal failure, particularly in elderly individuals. This vasoconstrictive effect appears to be reversible upon discontinuation of therapy. Another effect is the antiplatelet activity of NSAIDs. In order to understand the antiplatelet activity of NSAIDs, we need to explain the roles of endothelial-derived prostaglandin I2 and thromboxane A2 in maintaining vascular homeostasis. Normal platelet function depends partly on endothelial-derived prostaglandin I2, which blocks platelet activation and causes vasodilation, allowing blood to flow freely within vessels. On the other hand, thromboxane A2, a potent platelet stimulator and vasoconstrictor that is synthesized and released at the site of vascular injury. The antiplatelet activity of NSAIDs stems from their ability to inhibit COX-1, which is necessary for platelet-stimulating thromboxane A2 synthesis. Some in vitro evidence suggests that prostaglandin I2 synthesis is largely dependent on COX-2. Inhibiting the anti-aggregatory prostaglandin I2 may counter the antiplatelet effect, creating a prothrombotic environment. And this is the predominant theory of how selective COX-2 inhibitors increase the risk of adverse cardiovascular events. This figure illustrates the mechanism-based Fitzgerald hypothesis. Thromboxane A2, which is synthesized by the platelets through the action of COX-1 enzyme, is a potent platelet stimulator and vasoconstrictor, resulting in prothrombotic state. On the other hand, there is the endothelial-derived prostacyclin, which is a prostaglandin I2, which is synthesized through the action of COX-2 enzyme. Prostacyclin blocks platelet activation and causes vasodilation, resulting in antithrombotic state. Selective COX-2 inhibitors inhibit prostacyclin synthesis. At the same time, they leave thromboxane A2 generation unaffected, resulting in prothrombotic state. That's why selective COX-2 inhibitors increase the risk of adverse cardiovascular events. The last effect is the effect on uterine activity and ductus arteriosus. Exogenous administration of prostaglandin F2 and prostaglandin E2 has been used to induce uterine activity, and indomethacin has been used successfully as a tocolytic agent, blunting prostaglandin-mediated uterine stimulation to prevent preterm labor. However, a major clinical drawback in using NSAID as a tocolytic agent is the potential to cause premature constriction or closure of the ductus arteriosus in utero. Vasodilatory prostaglandins are required to keep the fetal ductus arteriosus open and patent, and inhibiting these prostaglandins has been shown to cause fetal ductal constriction, leading to pulmonary hypertension and persistent fetal circulation after birth.